everyone. I'd like to welcome you and thank you all for joining us for our first presentation of the Pacific Lipid Association webinar series. You're in for a fantastic presentation on what clinicians need to know about bempedoic acid by Dr. Bruce Warden and Ruth Schneider. So for those of you who are already members, welcome back. And for those of you who are new to the organization, we're excited to have you, and please consider joining our organization at www.lipid.org/memberships. It's an amazing community of providers with endless opportunities. My name is Jessica Durham, and I'm the president of the Pacific Lipid Association, and I will be the moderator of this session. I'm a nurse practitioner who is a clinical lipid specialist and the clinical coordinator of our lipid clinic in Seattle, Washington. I would sincerely like to thank the entire PLA board and the NLA staff, with a special recognition of Kathy Thompson for helping to make this project possible. We want to provide educational opportunities that can bring together local lipid clubs and virtually, and for individuals looking for great presentations with CMEs that apply to their clinical practice. Ruth, we really look forward to your presentation. Bruce, you as well. Please introduce yourselves.
Hi, my name is Ruth Schneider. I'm a nurse practitioner at UT Southwestern in Dallas, Texas. My primary focus is in preventive cardiology. Bruce.
Thank you. My name is Bruce Warden, a clinical pharmacist at Oregon Health and Science University's Center for Preventive Cardiology in Portland, Oregon.
So everybody, please submit your questions for our speakers by using the chat tab on the right, and submit your answers for the post-session poll under the polls tab. The accreditation information for the session will be emailed to you, and we hope you enjoy the rest of the series. Enjoy.
Bempedoic acid, what every clinician needs to know. I have no disclosures. My objectives: review phase 3 clinical trials focusing on the efficacy of bempedoic acid, discuss the place of bempedoic acid in clinical practice. We'll start with a patient case. 73-year-old female seen in follow-up for ASCVD risk reduction. Her past medical history includes heterozygous FH. She has a Dutch lipid score of 15. She also has an elevated lipoprotein A. ASCVD history includes she's had a prior stroke, and she also has carotid artery disease. Lipid-lowering medication intolerance. She has tried 4 different statins, developed myalgias with all of them. She is also intolerant of ezetimibe and niacin. She also has high blood pressure. She is obese. She has family history of FH and family history of premature cardiovascular disease. She has gout, hypothyroidism, and GERD. Her pertinent labs include she has a total cholesterol of 212, LDL-C is 97, her peak LDL previously was 283, HDL is 79, triglycerides 179, non-HDL 133, lipoprotein A is 58 milligrams per deciliter, and her uric acid level is 5.1. Her current medications include allopurinol, 200 milligrams a day, aspirin, 81 milligrams a day, cholecalciferol, 4,000 units a day, evolocumab, 140 milligrams sub-Q every 14 days, famotidine, 20 milligrams a day, fluticasone nasal spray as needed, and levothyroxine, 75 micrograms a day. Question: how do we manage this patient's lipid risk? All right, so bempedoic acid was approved in March of 2020. It was FDA approved for heterozygous FH and ASCVD in those 2 groups of patients that required additional LDL lowering. Wall Street Journal reported about it March 4th, 2020, and basically wrote, "Doctors see the drug as an alternative for millions of patients who can't take or aren't responding to statins." All right, bempedoic acid is in a class of medications called adenosine triphosphate citrate lyase inhibitors, ACL inhibitors. It's the first of its kind in that class. Bempedoic acid is an oral, once daily 180 milligram tablet. Nexletol is the brand name. It is also available in a fixed dose combination drug that consists of bempedoic acid, 180 milligrams, and ezetimibe, 10 milligrams. Brand name, Nexlizet. Bempedoic acid is approved in the US and European Union, as I previously said, as an add-on therapy to maximally tolerated statin therapy to lower LDL-C for patients with ASCVD and for patients with heterozygous FH. It is also approved in the European Union to treat patients unable to take any dose of statin or for whom a statin is contraindicated. All right, so mechanism of action. How does bempedoic work? It actually acts in the same cholesterol biosynthesis pathway as statins. Remember, statins target, inhibit, block HMG-CoA reductase. Bempedoic acid actually works upstream from that. When you ingest bempedoic acid, it is not in its active form. It is called a prodrug. It isn't until it meets up with the specific isoenzyme ACS-VL1 that bempedoic acid is converted into the active drug. Now, one piece of information to remember is that ACS-VL1 is not present in skeletal muscles. This mechanism of action that takes place only occurs in the liver. Once bempedoic acid is in its active form, it blocks the ATP citrate lyase, ACL, and leads to upregulation of LDLR, upregulation of LDL-C, and decreased plasma LDL-C. All right, so what clinical trials have been done that look at the efficacy and safety of bempedoic acid? Actually, there were 4 trials that looked at those 2 things. These trials included Clear Harmony, Clear Wisdom, Clear Serenity, and Clear Tranquility. I'm going to focus on the 2 trials on the upper part of the stream first, Clear Harmony and Clear Wisdom. These 2 clinical trials lasted 52 weeks, each of them. They looked at individuals that had ASCVD and or heterozygous FH that were currently on maximally tolerated statin therapy. Total number in Clear Wisdom, 779, 94% had ASCVD, 5% had heterozygous FH. In Clear Harmony, total number was 2,230 participants. 98% of those had ASCVD, while 4% had heterozygous FH. Looking at the bottom 2 clinical trials, Clear Serenity and Clear Tranquility, these individuals had ASCVD and or heterozygous FH or were primary prevention patients and were statin intolerant. These individuals basically were on low, very low, or no statin background therapy. If we look at Clear Tranquility first, it was a 12-week trial. Total number of participants were 269. 60% had hypertension, 19% had diabetes. None of them had ASCVD or heterozygous FH. In Clear Serenity, this was a 24-week trial. Basically, total number of individuals in the trial, 345. 39% had ASCVD, 2% had heterozygous FH. Okay, so What was the effect of bempedoic acid in these trials? Actually, this slide looks at all 4 trials and compares or looks at percent drop of LDL after 12 weeks. The baseline LDL varied from 103 to 155. And essentially what you saw, if we start at the left-hand side of the screen, Clear Harmony dropped LDL by a placebo-corrected difference of 18.1%. Clear Wisdom dropped the LDL by a placebo-corrected 17.4%. Clear Tranquility dropped LDL by 28.5%, and Clear Serenity dropped the LDL by 23.6%. So as you can see, bempedoic acid does what it's supposed to do. It drops LDL. All right, so this was another study that phase 3 clinical trial that was done. Essentially, the individuals in this trial, there were 301 participants. They either had ASCVD, heterozygous FH, or were high-risk CV patients. Basically, some of them were on full dose, maximally tolerated statin therapy. Others were on a lower dose. Others were on no statin therapy whatsoever. And essentially, they randomized these individuals into 4 groups: placebo group, ezetimibe group, bempedoic acid group, and then bempedoic acid and ezetimibe group. Essentially, what you saw after a 12-week period was looking at starting at ezetimibe, you saw a drop of LDL of 23.2%. In the bempedoic acid group, you saw a 17.2% reduction in LDL. And in the combined bempedoic acid and ezetimibe group, you saw a 36.2% reduction in the LDL group. All right, so bempedoic acid, well tolerated in statin intolerant. We found this out from the Clear Serenity trial. Remember, that trial looked at individuals that either had ASCVD, heterozygous FH, or primary prevention patients, but none of these, they had all been tried on 2 statin therapies previously, and they were intolerant to them. So basically, it compared side effects in this trial, looking at myalgias. In bempedoic acid, myalgias were reported in 4.7%, and in placebo, 7.2%. So bempedoic acid is well tolerated in statin intolerant. All right, so essentially, what did we learn from the bempedoic acid phase 3 trials? Bempedoic acid reduces LDL when administered as monotherapy or when added to stable background lipid-lowering therapies. Bempedoic acid provides an effective oral therapeutic alternative that is complementary to statins or other non-statin therapies. Bempedoic acid is an excellent option for the large number of patients that do not tolerate statin therapy due to muscle-related side effects. All right, so this slide, I just wanted to compare what we currently use for basically our high-risk patients. I took this from the European Journal of Cardiology, but we use these same drugs. And essentially, if you start with statins, which is always our number 1 choice. If you're looking at the high-potency statins, it's a torvastatin, 40 to 80 milligrams a day, or rosuvastatin, 20 to 40 milligrams a day. Expected LDL reduction with these 2 medicines is greater than or equal to 50%. If you look at ezetimibe, 10 milligrams a day, as monotherapy, it can reduce the LDL by 18.5%. When added to statin therapy, can reduce the L by 20 to 25%. Then looking at the PCSK9 inhibitors, evolocumab, alirocumab. Remember, these are both sub-Q injections, one injection every 14 days. When they are used as add-on therapy, can reduce the LDL by 50 to 60%. Now we have bempedoic acid, 180 milligrams a day. It can reduce as monotherapy the LDL by 23%. In combination with ezetimibe, can reduce the LDL by 35%. Again, I hadn't talked about it earlier, but wanted to bring up, we are waiting for the CLEAR outcomes trial to be completed. Essentially, that we know that LDL reduces, that bempedoic acid reduces LDL. We assume that cardiovascular risk will also be reduced, but the CLEAR outcome trial, when it is completed, will have that information for us. Okay, so I threw in the 2019 European Society of Cardiology guidelines. One of the reasons I did that is in practice, we typically, in the AHA, ACC guidelines, we look at reducing LDL to less than 70. But in practice, for our very high risk patients, we many times try to reduce the LDL to at least less than 50. So why are the European guidelines and why are the AHA, ACC guidelines different? One of the reasons is that the American AHA, ACC guidelines take cost consideration into when writing their guidelines, okay? So the European guidelines basically say, barring everything, looking at in the ideal situation, what would we like to see? And that is one of the reasons for the difference in the LDL goals. So to go over their goals a little bit, in secondary prevention for patients that have very high risk, an LDL-C reduction of greater than or equal to 50% from baseline, and an LDL goal of less than 55 is recommended, a 1A recommendation. In primary prevention for individuals at very high risk, but without FH, an LDL reduction of greater than 50% from baseline, and an LDL goal of less than 55 is recommended. 1C recommendation. In primary prevention for individuals with FH at very high risk, an LDL reduction of greater than 50% from baseline, and an LDL goal of less than 55% should be considered. For patients with ASCVD who experience a second vascular event within 2 years, not necessarily of the same type as the first event, while taking maximally tolerated statin-based therapy, an LDL goal of less than 40 may be considered. In patients at high risk, an LDL reduction of 50% and an LDL goal of less than 70 is recommended. In individuals at moderate risk, an LDL goal of less than 100 should be considered. In individuals at low risk, an LDL goal of less than 116 should be considered. All right. So this next slide basically looks at the American Association of Clinical Endocrinologists and the American College of Endocrinology. They came out with the updated LDL goals in late 2020. So bempedoic acid had been approved at that time. I just essentially wanted to show you across the board from extreme risk to very high risk to moderate risk to low risk. They added bempedoic acid in. It's always statins are recommended initially. And then if there is further additional LDL lowering that is required, PCSK9, ezetimibe, Welchol, or bempedoic acid may be considered depending on the LDL lowering required. All right, so going back to the AHA, ACC guidelines, these are from 2018, and this slide looks at secondary prevention. Where do we see bempedoic acid fitting in? For now, it's over here in the very high-risk ASCVD patient. Again, they're going to start with a high-intensity or maximally tolerated statin therapy, then typically ezetimibe is recommended. Again, depending on the LDL lowering that is required, we may recommend bempedoic acid in place of ezetimibe or in place of PCSK9. Then looking at primary prevention, where does bempedoic fit in? I think it falls in with any of those individuals that have heterozygous FH that are not reaching their LDL goal by their current with their current statin therapy, and or if they are on PCSK9 and still not at goal, I think you can consider bempedoic acid at this time. All right, so FDA approval for bempedoic acid, as said previously, right now as it stands, is for ASCVD or heterozygous FH. It is recommended with LDL lowering needed beyond current statin therapy. However, when the CLEAR Outcomes trial is completed, we anticipate statin intolerance to be included on the label.
Great, and thank you, Ruth, for that wonderful presentation. Hello, everyone. My name is Bruce Warden. I'm a clinical pharmacist at Oregon Health and Sciences Center for Preventive Cardiology. I'm going to be going over the bempedoic acid and continuing our program on this agent. My disclosure slide is listed here. And what I hope to convey over the remaining program is really looking at safety parameters and how we can monitor those and at what interval. Viewing ways to improve medication access and reduce patient out-of-pocket cost. And then finally, take a glimpse into the real-world experience within our Center for Preventive Cardiology to see our clinical use of bempedoic acid over the past year or so. So I want to start with the notion that bempedoic acid overall is a very well-tolerated therapy. If we look at the clinical trials, there have been 4 phase 3 trials evaluating just over 2,000 patients on bempedoic acid. And what we see is that treatment emergent adverse events, so side effects, are really no different bempedoic acid as compared to placebo. We do see a slight increased risk of drug discontinuation due to side effects of bempedoic acid in roughly 11% as opposed to 8% in placebo. And in particular, in our most vulnerable population, the statin intolerant patients, we see that the tolerability of bempedoic acid is really on par with other non-statin therapies that we use in the statin intolerant population. So in Clear Serenity and Clear Tranquility, drug discontinuation with bempedoic acid in the statin intolerant patients was slightly elevated compared to placebo at 18%, but again, similar to what we see with the ezetimibe and with our PCSK9 monoclonal antibodies, evolocumab and alirocumab in their statin intolerant trials, the GAUS-2, GAUS-3, and Odyssey alternative. Now, the main side effect that we worry about with any lipid-lowering therapy is muscle symptoms. These are being myalgias, myopathies, muscle cramps. And with bempedoic acid, this was the primary reason why this was developed. We see that there's no difference in muscle symptoms bempedoic acid as compared to placebo. And this is because this is built into how the drug works, its mechanism of action. It's a prodrug, it's inactive or inert, and it only becomes activated in a very hepatocyte-specific, very long-chain acetyl-CoA synthetase, where it adds an acetyl-CoA group to bempedoic acid and allows it to inhibit cholesterol biosynthesis. But in other tissues, in particular skeletal muscle tissues, we don't see that effect, and we just have an inert drug that does not affect cholesterol biosynthesis. And importantly, preserves these biological intermediates to improve cell membrane integrity and muscle cell health. When we look at overall treatment side effects, the most common ones that we see really occur very rarely, less than 8% of total patients, and they're nondescript symptoms, or symptoms that you're going to see really in any randomized controlled trial. Nasopharyngitis, dizziness, fatigue, and really no different from what we see in placebo. But what I want to spend a portion of time evaluating now are what side effects actually occur at a higher incidence in bempedoic acid group. And I've broken these down by organ system, and we'll start with drug interactions, cardiovascular, renal, tendon, gout, hepatic, and then blood dyscrasias. So being a pharmacist, you know we're going to start with the drug-drug interactions. And reassuringly, bempedoic acid has no involvement with cytochrome P450. And this is a very important concept because this is the most common enzyme system that's involved with drug-drug interactions. Now, we do see bempedoic acid is a weak inhibitor of certain transporters, specifically the OAT transporters, organic ion transporting polypeptides. And this is important specifically when co-administering with statins. And so the figure on the right here is looking at statin biotransformation in the body. There are many enzymes and transporters involved, but what I want to focus on are the ones circled here in red, the OAT transporters, which allow for statin hepatic uptake. And what we see with co-administration of bempedoic acid, we block this, and thus we get an increase in plasma statin concentrations. Now, the prescribing information has recommended avoiding the maximal doses of pravastatin and simvastatin, as these are the most commonly affected by the OAT transporters. And we see about a twofold increase in plasma concentrations when given with bempedoic acid. Now, no other statins are called out, no other dosing recommendations, and the others seem to be well tolerated in the randomized controlled trials. But I will give you this air of caution, and that is other statins are affected. So atorvastatin and rosuvastatin, when given with bempedoic acid, we see about a 1.7-fold increase in plasma concentrations. And for the majority of patients, I don't think this is going to have any clinical consequence. But for our very medication-sensitive patients, our statin-intolerant patients, or patients who are on very low doses of statins, say rosuvastatin, 5 milligrams 3 times a week, the increase in the statin concentration induced by bempedoic acid may be enough to cause some symptoms. So just be very cautious in that group. Bempedoic acid also inhibits another OAT transporter in the renal tubule that's important for serum creatinine and uric acid secretion that we'll talk about in just a bit. Now, looking at the cardiovascular system, one that I want to highlight is risk of AFib development or atrial fibrillation. We see a very slight increased risk with bempedoic acid as compared to placebo. And I really bring this up because this is not the first time we've seen this with lipid-lowering therapy, right? We see this with our omega-3 fatty acids as well. So like the omega-3s, the mechanism of action is really undetermined at this point, and this is something we need to continue to monitor. But reassuringly, we see no increased rates of increased stroke, which is the major complication of AFib. On the vascular side, we see a compilation of blood dyscrasias that are really overall pretty minor, and we're not quite sure how these develop or what to make of these, but we need to monitor them. So we can see laboratory changes within the first 4 weeks. They're generally stable and generally reversible. And what we see is that for the most part, there's no increased risk for negative clinical sequelae. So though we can see increased rates of anemia, we don't see increased rates of transfusions. We see thrombocytosis, but no increased rates of thrombosis. And we can see a leukopenia and neutropenia, and for the most part, no increased risk of infection. Though the one caveat, the asterisk here, we did see a slight increased risk for skin and soft tissue infections with bempedoic acid, predominantly cellulitis, but this was very rare, less than 1% of patients. But given a high-risk cardiovascular population that we'll likely be treating, I think these are two conditions that we need to monitor closely. Moving on to the renal system, I always get the question, what's the effect of the drug on the organ and the organ's effect on the drug? And here, bempedoic acid is highly renally clear. It's about 70%. And for mild to moderate degrees of chronic kidney disease, so creatinine clearance greater than 30 mils per minute, the change in plasma concentrations of 1.4 to 1.7 really there's no clinical significance that we need to make any dose adjustments. But what we don't know is what's the effect in severe kidney disease, so creatinine clearance less than 30 or those on hemodialysis. This is an area that requires additional investigation. And in terms of bempedoic acid's effect on the kidney, it's really a fairly benign medication. You will see, because of the OAT inhibition, some increase in serum creatinine and BUN, and a very slight decrease in EGFR. But know that this isn't compromising the kidney's ability to clear medications or proteins. It has not been shown to be nephrotoxic, but this again is something that we should keep an eye on. And then we did see a slight increased risk of benign prostate hyperplasia in bempedoic acid, up about 1%. The mechanism and clinical significance of this is really unknown, but given the elderly population will likely be treated, something to be aware of. Now, the hepatic system, as I mentioned, bempedoic acid really has very little reliance on hepatic biotransformation, no CYP involvement. But there is the hepatic activation from the prodrug to the active bempedoic acid. But that's any degree of hepatic impairment thus far, from mild to moderate, really seems to have very little effect on plasma bempedoic acid concentrations. we see a reduction of about 10 to 20%, which should not change any of the efficacy measures for bempedoic acid. But again, similar to what we see in the renal system, we have not evaluated this agent in severe forms of hepatic impairment. So that needs to be investigated. Now, the drug's effect on the liver, we see a very slight increased risk of LFTs, but for the most part, they're transient and very minimal. More clinically significant increases, so 3 to 5 time increase in the LFTs, is really very rare, less than 1%, and no different from placebo. And thus far, no reports of hepatotoxicity. But again, something that we need to keep an eye on, as this is a new medication. Now, taking a look at gout, this is one of the conditions that is listed as a warning in the prescribing information. And in the overall population, gout incidence is very rare, 1.4% in bempedoic acid group. And again, this is occurring because bempedoic acid inhibits that OAT transporter in the renal tubules, preventing uric acid secretion. And this is very much a dose-dependent effect. On the x-axis here, as you increase bempedoic acid dose, you increase plasma uric acid concentrations. Looking at the figure on the right, we see that the increase in uric acid is first noted within the first 4 weeks and remains relatively stable. So we get roughly about a 16% relative risk increase, which equates to about 0.8 milligram per deciliter increase in uric acid. And then upon drug discontinuation, it goes back to baseline. And so for the majority of patients, this is not an issue, but those that have a history of gout or elevated uric acid at baseline, we see a 10-fold increase in gout attacks, up from 1.4% in the overpopulation to 11.2% in those with a history. And so this isn't a contraindication or anything of that measure, but it does require patient to clinician shared decision-making about risks and benefits. Tendon rupture is another condition that got listed in the warnings and the prescribing information. And this isn't anything new to lipid-lowering therapy. There's been a questionable association with statin use and tendon rupture as well. And we kind of see the same thing here with bempedoic acid. Tendon rupture, very low risk, 0.2%. If you include rupture and injury in the definition, it's 0.5%. And this seems to be affecting more of the upper extremities, so the bicep tendon, the rotator cuff, more so than the lower extremities. Now, personally, I don't think this is much of a drug-induced effect. I think this has more to do with concomitant medical conditions that are predisposing them. And if we looked at those that had tendon issues, nearly all had some sort of trauma or stress at baseline, or had a history of tendon injury. All were on moderate to high intensity statins, and all had one or more risk factors. And as you can see, many of these risk factors, I mean, hypercholesterolemia is consistent amongst them all, but many of these our patients are going to have. And so when I look at this list, I look at what ones are modifiable. So we're looking at other drugs that may be inducing tendon rupture. And so we know fluoroquinolone and corticosteroids over the years have a history of up to about a 2% risk of tendon rupture. So I just try to make sure that my patients aren't co-prescribed with these medications. And then again, counseling them on early signs and symptoms so that if there is an issue, we can evaluate. Now, the last safety concern I want to go over are concerns with pregnancy and lactation. And again, this isn't new to bempedoic acid. This is pretty much wideswept across the lipid-lowering therapies. And the general consensus is to avoid during these two conditions. We have minimal human data to guide this, but we do have some animal data. With bempedoic acid at toxic doses, we can see some really negative outcomes with the fetus in terms of reduced survival rates, reduced growth pattern, and cognition. At lower doses, we can see some minor skeletal variations in terms of bent long bones and incomplete ossification. As relates to lactation, I don't expect bempedoic acid to be heavily excreted in the breast milk because it is so highly protein bound. But regardless, just because of the mechanism, cholesterol production inhibition, there is possible harm to the fetus and infant. And for most cases, should be avoided. In more severe, say, FH phenotypes, a patient to clinician discussion should occur. Now we've gone over what conditions warrant monitoring. Let's look at what interval. And so I've broken this down into laboratory assessment and clinical assessment. Those that are highlighted in red, lipids, gout, and tendon rupture, are the monitoring parameters that are spelled out in the prescribing information. And then the rest are kind of my clinical assessment. So at baseline, I think it's very helpful to get a list of everything so we can see any changes related to baseline. So we'll get lipids, and then the first time point we'll check again is somewhere between month 1 and 3 post starting bempedoic acid. We'll get a repeat lipid panel, a complete metabolic panel, and then every 6 months thereafter. We'll also get a baseline A1C because there is some positive improvements in glycemic control, though minimal with bempedoic acid. We'll get that annually as well as with a complete blood count. And then we'll use an as-needed recheck of the uric acid based on a few things. If they're having symptoms for sure, or if they are at higher risk. So a gout at baseline or a history of high uric acid levels. And then for the clinical assessment, which I recommend doing at every patient encounter, screening for drug-drug interactions, so avoiding maximal doses of pravastatin and simvastatin, and making sure that patients are not on fluoroquinolones or corticosteroids. And then for atrial fibrillation, gout, and tendon rupture, assessing the patient for signs and symptoms and addressing accordingly. And then for patients that are of childbearing age, discussing risks and benefit in pregnancy and lactation. So we'll go ahead and shift gears slightly now and look at medication access and cost. And so bempedoic acid, like other branded cardiovascular drugs, is expensive. Its cash price is somewhere in the range of $350 to $450 per month. And if we stack that up against other branded lipid-lowering therapies, or PCSK9 inhibitors, or our icosapent ethyl, it's really on par with what we see with those therapies. But overall, it's less than we see with our novel diabetic agents with cardiovascular preventive properties, so our SGLT2 inhibitors or GLP-1 receptor antagonists, but still about a 40-fold more expensive than we see with our generic first and second line therapies, or statins and ezetimibe. So our group published a paper here just recently that looked at access to these branded cardiovascular risk-reducing medications. And we found that 3/4 of the patients after prescribing will require some post-prescription intervention, which we defined as needing an authorization, an insurance appeal, or some cost-saving measure like a copay card or patient assistance program. And the same is true for bempedoic acid. As it recently was approved in February of last year, it's still trying to find its footing on the insurance formulary platform. And then when I'm looking to reduce costs, there's kind of a three-prong approach that I recommend. First, and the biggest, is making sure you get insurance approval. That's going to be the biggest reduction in costs. So in this example here, the drug will say it's $400 per month. With the insurance approval, now you've dropped that down to say $100 per month copay. Then depending on what type of insurance they have, that frees you up to see what cost-saving measures there are. So for private or commercially insured patients, all those patients are available to get manufacturer-assisted copay cards. So in this example, that would drop the copay down to $10 per month. But for our Medicare population, which is a little more challenging, they are by law ineligible for copay cards. And so we have to use these foundation grants. And there's two out there, Healthwell Grant and the PAN Foundation. I've listed their websites down there. These have been instrumental in allowing our Medicare patients, who generally pay much higher copays, some financial assistance. So please check those out if you don't know about them. Tips for insurance approval. I get this question all the time. Bruce, what is the secret to getting XYZ drug approved? And really there isn't one. Nor is there a magic wand. I have a process that when followed works very well. And so again, this can be applied to bempedoic acid or really any other branded cardiovascular drug. And so the first is making sure we're prescribing under the FDA approved or clinic or indications recommended in the clinical trials. So FH and or ASCVD with bempedoic acid, though by default, many of these patients will be statin intolerant. Statin intolerance in and of itself at this point is not a approved indication. After that, determining what background therapy they're on and documenting it. So not only what they're currently on, but also what they've been on previously, which this can be the challenging part because sometimes you're having to go through decades worth of data to see what statin they were on in the 1980s when they first started. But this is very important, not only for insurance approval, but really as a roadmap to see what agent you may need to try in the future. So I document what is their maximum tolerated statin. Now know that for some patients, that maximum tolerated statin is 0. They can't tolerate any, they're statin intolerant, and we document that. And then possibly depending on patient risk and preference, background ezetimibe and or PCSK9 inhibitor therapy. Know that these are not requirements and that the trials used low doses of this or low frequencies of these, so about 15% background use of ezetimibe and less than 1% for PCSK9 inhibitors in the phase 3 trials of bempedoic acid. And then next is the why. Why bempedoic acid over XYZ? And I leverage 3 items here: indication, the degree of LDL reduction, and the side effect profile. So as an example, I recently had insurance deny bempedoic acid, requesting that the patient use fenofibrate in its place. And so fenofibrate lacks an ASCVD risk reduction indication. It is more of a triglyceride lowering medication with really minimal reduction in LDL. And its side effect profile does include myalgias, which this patient had failed numerous statins and other therapies because of myalgias. And so I leveraged that, and the bempedoic acid was approved. So very important, document. Now, even at your best attempts, the perfect candidate for bempedoic acid, you're going to get a portion of patients that are denied. Don't be afraid to appeal. A short half-page appeal letter a lot of times is the difference between a denial and a patient never starting it and an approval and a patient being on this indefinitely. So now I want to take a little bit of a glimpse into our real world experience. So with the use of bempedoic acid. So over the course of about 14 to 16 months, we had 73 patients that were prescribed bempedoic acid. And we are in the final stages here of getting this report submitted, and you'll see much more granular detail there. I just kind of want to give you a peek at the data. We had an elderly population. This is an important one. Almost 84% of our patients were female, which in contrast to randomized controlled trials is much higher. Females are usually very underrepresented. But I think the driving force of that is that we had 3/4 of our population was statin intolerant. As female gender is a risk factor for statin intolerance, I think this makes sense. From an atherosclerosis standpoint, our patients were at very high risk, almost 90% with established ASCVD and 2/3 with heterozygous FH. And because we had a high incidence of statin intolerance, we had a high use of non-statins at baseline. So 50% were on ezetimibe and 50% on PCSK9 inhibitors at baseline. And then really a compilation of many other cardiovascular risk factors that, again, makes this a high-risk patient. From when we saw the patient to when they actually started the drug, there was a lapse of about 41 days. Most of that was working on getting insurance approval and cost-saving measures. Over half of our population were Medicare patients, again, making cost-reducing principles more challenging. What we saw is the median monthly drug cost was $432, reduced to $80 with insurance approval, and then reduced to $10 per month with cost reduction measures. So a 40-fold reduction in cost. And importantly, this is under $50 per month. And that $50 per month mark is very important because medication adherence really drops off if you surpass that mark. With the process that we had just mentioned, approval rates were 97%. And know this, that anytime you prescribe bempedoic acid, you are going to need to have some post-prescription intervention. So almost 95% of our patients required an authorization, an appeal, or a cost-saving measure. So the process does not stop with signing the prescription. If we look at the 73 that were prescribed, there's a few important points that I want to highlight, and that is almost 44% of our patients are currently not on therapy. Now, a portion of these, they're pending. We're waiting for them to get insurance approval or pick up the medication from the pharmacy. Despite our cost-saving measures, a portion of patients weren't able to afford it. We had one loss to follow-up, one where the drug was ineffective, but the vast majority of the reason why patients aren't on therapy is because they discontinue it due to side effects. So almost a third of patients. And this is in stark contrast to what we saw in the randomized controlled trials, where about 11% discontinued due to side effects. And there's a few items here that are worth investigating, but one is we have a very high-risk population. Almost 84% were statin intolerant. So like what we see with statin trials, statins are well tolerated in clinical trials, but in clinical practice, it's a different story. And I think we're starting to see that here with bempedoic acid as well. 50% of patients had any adverse drug reaction. Ironically, the majority of those were muscle and skeletal related in nature. So myalgia, arthralgia, myopathies. And we had a whole host of a wide range of side effects from tendinopathies to neutropenia to gout effects as well. So those monitoring parameters were in there for a reason, because these are things that we see in clinical practice as well. I'll go back here. There's one additional talking point. So we have 56 patients taking, but we have a small subset of patients that are on a subtherapeutic dose, so less than 180 milligram per day, 45 or 90 milligram. And these patients, we either preemptively prescribed a lower dose, or they had side effects and we dose reduced. Now, I'm not advocating this as a routine strategy, but in patients who are very medication sensitive, this may be the difference between them taking the medication and not. And the lower dose still affords some LDL reducing properties. So this is looking at LDL reduction based off of dose from the FDA product review. And we see this with statins, we see this with ezetimibe, really any enzyme or transporter inhibitor. Just getting a little bit of drug on board is enough to confer the majority of the LDL reducing capabilities. So with bempedoic acid at the prescribed dose, 180 milligram, you get roughly a 30% drop in baseline LDL. At a half dose, we'll say 90 milligrams, you still have about 25% LDL reduction. And at a quarter dose, 45 milligrams, you still have about 18% reduction. So in select very high-risk patient, a lower dose may be applicable. In our overall population, what we saw at that first time point checked, month 1 through 3, a 37% reduction in LDL, which is a little bit more robust from what we see in the clinical trials. The LDL reduction was maintained at month 6. I wouldn't put too much emphasis on the month 12 yet. We just had such few samples because the drug was just approved just over a year ago that we'll have to wait and see how additional follow-up looks like. But it seems to retain the LDL lowering efficacy. But what I also wanted to highlight is the range of LDL responses from 0% to an 80% reduction. So a wide range in LDL responses. And we'll discuss this more in the paper, but we had almost a bimodal distribution where we had a portion of patients who we termed hypo-responders, so less than 10% reduction, and a portion of patients whom we termed hyper-responders, so a greater than 50% LDL reduction that I think requires some continual monitoring. So we return back to the case. Our patient was started on bempedoic acid, the standard dose 180 milligram once a day. She's been on this for over 6 months now and tolerating it very well without any adverse events. Her baseline LDL was 97, reducing down to 71 at the first time point, a 27% reduction. And then at month 6, an even greater reduction, 58% reduction now, LDL of 41, and she is at her LDL goal. Now, this further reduction between months 2 and 6 occurred without any changes in baseline medications or lifestyle interventions as well. Because she had a history of gout, we checked pre and post uric acid levels, found that there was no change, and the patient is asymptomatic from a gout standpoint. So tolerating it very well. So to wrap up then, bempedoic acid is a welcome addition to our growing armamentarium of lipid-lowering therapies. It's nice to have an add-on drug in severe FH phenotypes or in patients with ASCVD, and I'd likely will carve out a role for statin-intolerant patients. It has modest LDL-lowering capabilities, though we seem to see a slightly more robust response in clinical practice. And the randomized control trials demonstrate that it is it's a well-tolerated therapy, but in our high-risk patients, particularly our statin-intolerant patients, there seems to be a pretty high rate of drug discontinuation that we'll have to continue to monitor. And as we await the cardiovascular outcome trial results, know that bempedoic acid is already establishing itself as a niche therapy within lipid management. So thank you very much for your time and attention, and I look forward to any questions you may have. Thank you.
The presentations were just fantastic, and we've got some great questions waiting for us as well. And so would you guys like to make any comments, or would you like me to go ahead and just jump right into those questions?
Yeah, let's go ahead and field the questions here.
Excellent. So we've got some questions regarding specifically looking at the guidelines. So I'm just going to go ahead and read it. And so based on the recent 2021 ACC expert consensus decision pathway on the management of ASCVD risk reduction in patients with persistent hypertriglyceridemia, the case Ruth presented would fall into the LDL of 70 to 99 with ASCVD. In this case, shared decision-making would be needed to use a triglyceride risk-based approach and really sort of questioning, would it be helpful to consider something like icosapent ethyl versus additional add-on therapy to lower your LDL, given the fact that bempedoic acid has not been shown to reduce MACE as of yet. And so just curious about where you think this EPA-only fish oil would play a role. Who would like to take that?
And refresh it, what was the patient's triglycerides? Do we have that up?
And
looking to see, but yeah, no, I mean, that's great. A great question in terms of looking at evidence-based therapies for cardiovascular risk reduction. I can't recall if this patient would have met criteria for that. And she did. She had triglycerides of 179, elevated non-HDL.
Yeah.
So either option I think could have been discussed there. And I'm not sure what had transpired in those patient discussions. Items looking at pill burden, cost differences, where we think the risk truly lies, whether it is in triglyceride-rich lipoproteins or in that particular patient with FH, if it was more an LDL-based strategy. that's conferring more of the atherogenic lipoprotein risk. But no, it's a fantastic question. I think you could probably go either way with that. So this patient had a peak LDL of upwards of 283. So I think the thinking may have been that may have contributed to the majority of her risk, but definitely items to look at follow-up.
Absolutely. And, you know, it's nice that we have all these options now in our toolbox to consider.
I know. Right? And that presents, I think, a whole nother challenge, right? Like, is it icosapent ethyl? Is it bempedoic acid? Now we do look at GLP-1 or SGLT2. What therapy is going to confer the greatest risk for the benefit and also fit in line with the patient's preferences and potential risk for side effects?
Absolutely. And I couldn't stress more that shared decision making is really where that decision is made, right? In the discussion with the patient to really outline their risk and figure out what the next best step will be. So wonderful. We have another question regarding the pleiotropic effects. Do we expect to see similar levels of reduction in inflammation, changes in the fibrinous cap? Are we, given the pathway being so close, Bruce, do you see, reductions in hsCRPs in your data?
We did. And in the clinical trials, I think it was upwards of 20-30%, kind of on par with what we'd see with statin therapy, which may be another salient point or a glimpse into what we may see with cardiovascular outcome trials. But there is an anti-inflammatory effect there. And in our real world analysis, we saw that as well. I think actually a little bit more robust. I want to say 50% or so reduction.
Wonderful.
Yeah.
And so moving on to the next question here, in a patient with a recent ASCVD that is truly statin intolerant, is there data to show superiority with starting bempedoic acid versus PCSK9 versus PCSK9 alone?
I mean, I think based on FDA approval, we would start with the PCSK9 at this point. Yeah, awaiting outcomes on bempedoic acid, but at this point, PCSK9. Bruce? Yeah,
no, I would echo those points too. Looking at evidence-based therapy, we have 2 large cardiovascular outcome trials with PCSK9 inhibitors, one particularly in a post-ACS setting there. And then we have to look at, obviously, the degree of LDL lowering that's required. 50 to 60% with PCSK9 on average, versus more 20-25% with bempedoic acid. So the absolute risk reduction would obviously correlate with the degree of absolute LDL reduction. And then, obviously, patient preference comes into play. You're talking about a parenteral therapy now versus an oral drug once a day versus every 2 weeks. So those are other, I think, minor factors to evaluate, but still would go into the decision.
Absolutely. Thank you for that. So switching gears here just a little bit and away from LDL and really focusing on the triglyceride and HDL levels, what impact does the bempedoic acid have on those specific markers?
Go ahead, Bruce.
Okay, the triglyceride, really minimal to no effect and similar with the HDL as well. I think there's maybe a slight increase, but it's minimal to none.
Focused on that LDL, yeah.
Yeah, very much focused on LDL reduction.
Thank you. So we have a friend, I think maybe from Canada, who's wondering when this might be available in Canada. Any idea on that, guys?
Sorry, I have absolutely no idea.
I don't. I was searching, trying to find something online. I wasn't able to find it either.
I don't know. I guess the question would be, does it have other novel drugs like PCSK9 inhibitors kind of followed suit with the FDA in terms of approval and access? That would probably be your best template or marker to see if this will follow suit. But I imagine it would, or maybe they're waiting for the outcome trial data.
Sure. It sort of feels like we're back to the ezetimibe roller coaster, right? Of waiting for the data and having it added on a little bit. So hopefully that event reduction data will help to clarify things a little bit more. Okay, so next question is, for patients who are uninsured, are there patient assistance programs available?
Not that I'm aware of, on bempedoic acid at this point.
No, the copay cards, to my understanding, and everyone is a little bit different, but there's a copay card and then there's a discount card. And so my understanding of bempedoic acid, the copay card, the fine print, if you read it there, will say after approval from insurance. So you have to have the insurance approval before that'll kick in. Now there are some other therapies that label it more as a discount card, and that seems to be able to be applied with or without insurance. We see this a lot with our anti-obesity medications like Saxenda and the new Wegovy. Many times insurances won't cover it, but you can have like a $200 off discount card, which is no longer a savings card. But for bempedoic acid, it doesn't appear so. There isn't a manufacturer-derived patient assistance program like we had with Repatha, and I think we had with Praluent. The foundation grants are all from patients who have Medicare Part D, the prescription coverage. So that would be, a loophole. The patient who would likely have to pay out of pocket or not at all. I mean, it's $300, $400 a month, which is very steep.
Absolutely. I'm sorry, I missed this question from earlier. It ties back to the triglyceride and HDL, but it was sort of a second piece of it. Did any of these studies look at small, dense, or lipoprotein a, even in the subsamples of these studies?
Bruce, I didn't see that.
Yeah, I don't think, to my knowledge, that they evaluated the density of the LDL. I'm trying to recall what I look at Lp(a), but there was no effect on Lp(a) reduction, which I think would mechanistically make sense. I mean, with statin therapy, we actually see maybe a slight bump in Lp(a) to no change. So.
Excellent. It's interesting. We've got a lot of icosapent ethyl questions here. So
yes.
Talking about the combination of using the EPA-only fish oil with bempedoic acid, are there any contradictions or concerns with this combination? Maybe even focusing specifically on the AFib?
Bruce?
Yeah, I mean, that's a fantastic question, and nothing to really guide other than clinician experience and patient decision. I still think we're getting more data to show that a dose-dependent effect with the mixed omega-3s, as well as the EPA-specific fish oil. Mechanistically, what is driving that? I think we're still trying to iron that out. Bempedoic acid does have some effects on altering fatty acid metabolism by decreasing acetyl-CoA production. So maybe that's a common link between the two, is some sort of alteration in fatty acid metabolism. But whether or not that's additive, synergistic, or no difference in terms of AFib risk, that's going to require some further investigation. But it's a salient point and something to discuss, because a lot of these patients are going to be elderly, metabolic syndrome, overweight, right? These are hypertension. These are classic risk factors for AFib as well.
Great point, Bruce. Really great point. So let's see here. There's another question regarding routine monitoring of uric acid and sort of your approach on routine monitoring versus a threshold for interrupting therapy. And I would even sort of expand on that question and just say, are you actually seeing gout flares, or are you just seeing changes in those uric acid levels?
We've seen both. They've been minimal. We actually had one patient, no history of gout or hyperuricemia baseline, but had a doubling, almost tripling of their uric acid. That didn't ever seem to reach the peak. Every time we checked it, separated by 2 to 3 months, it would continue to escalate. That made the care team, which involved the primary care doctor as well, a little nervous. Just long-term effect, elevated uric acid levels, not only in gout, which I think we all think of, but it can precipitate kidney stones. There can be adverse effects on bone metabolism too. So we actually elected to withhold therapy in that patient. But the patients that we did see gout attack actually did not have a history, and it was very few, a handful. We did not see a history of gout at baseline, which seems to be the #1 risk factor. But our general approach would be to get a baseline, and then unless they have elevated uric acid at baseline or a history of gout, we generally don't repeat it unless they're having some sort of symptoms that we're concerned with gout or, like I said, kidney stone or anything of that nature.
Wonderful, thank you. The next question is regarding glycemic effects and what's been observed, and could this sort of follow down the pathway that we've seen with I'm gonna stutter because I always say this. Well call, right? Sorry, the generic of the I just butcher it every time. So, do we expect to see any additional information come out on the glucose response?
I hope so. It's very minimal. It's less so than the bile acid sequestrant, so colesevelam, which actually has an FDA approval for as an adjunct therapy in diabetes because of the degree of A1C reduction. So we see 0.4, 0.5% reduction in A1C. And in my understanding, it's binding glucose and sugars in the GI tract before they're absorbed. For bempedoic acid, the mechanism of which I think is still undetermined, but again, may involve that alteration in fatty acid metabolism, but it seems to be much more milder, so 0.1% reduction in A1C, which I think is a milligram per deciliter. It's 3 to 5 milligram per deciliter, something along those lines.
Do we hear a possible new indication?
I don't think so.
Okay. All right. So just as we wrap things up here at the end, I'm just curious, we've mentioned a number of times that we're really waiting on that event reduction data. Do we have a little bit of a timeline on when to expect that?
2022 is what but they said, I spoke to someone the other day that said it may be early 2023 before everything is basic, before we get all the information.
Excellent. Thank you.
Have you heard anything other?
Sounds good to me.
And I just want to thank everybody again for joining us for our first Pacific Lipid Association webinar presentation, and sincerely thank Dr. Bruce Warden as well as Ruth Schneider for wonderful presentations. Thank you both.
Thank you.
Great. Thank you for having me. Appreciate it.
Have a great day, everyone.